Hello, CTSNet community. My name is Brian Mitzman, thoracic surgeon with NYU Langone Health. We're continuing our COVID roundtable series with another important question. What operations are considered elective in the world of thoracic oncology? My guest needs no introduction. Dr. Doug Wood, chair of surgery at the University of Washington, past president of the STS, and international leader in our field. Dr. Wood, thank you for making some time to chat today.
Brian, happy to join you. And it looks like we are both in environments outside of our normal offices.
That is right. So let's jump right in. In light of the continuing lack of resources, including hospital beds for patients, many institutions are initiating strict policies on booking non-emergent operations, really preparing for the surge of patients that could be coming or are already here. What's the current policy to book non-emergent surgery at the University of Washington right now?
Yes, Brian. Well, as you know, Seattle, one of the epicenters, now overshadowed by New York City, but one of the epicenters of coronavirus infection in the United States. And as we have prepared for the surge of anticipated patients, we made the decision now 2 weeks ago to cease elective surgery. And so that ceased on March 16th. So we're now nearly through 2 weeks of cessation of elective surgery. And obviously, the challenge there is what's the definition of elective? And I know that's what we're going to be talking more about in a few minutes, but at least in the broad category, it was considered things that did not need to be done within the next 4 weeks, and that was kind of the time frame that was put around it. It's an arbitrary time frame, and that procedures that there would be a poorer outcome or potential harm to the patient if it wasn't done within 4 weeks should proceed. There's some bright lines, some things that obviously fit on the elective side of that, and some things that obviously sit on the urgent emergent side of that. But, as we're going to be talking about, there's this gray zone in the middle of urgent cases and how to triage them in a time that we are resource limited.
Right. And you specifically just used the word triage. There is this gray zone of who determines what kind of case can wait 4 weeks. Has your division of cardiothoracic surgery specifically taken any steps in who decides what cases should get booked? Is there a group peer review process at this point?
Yeah, it's a great question. And I'm sure that different systems are going to have different ways of approaching this, and maybe different ways depending on what phase of resource limitation that they have. Currently, we moved into this process with it being quite clearly determined by the surgeon. The surgeon would be the arbiter of whether a patient was urgent or non-urgent elective. And the reason for this at this stage of mildly limited resources, but not at the crisis stage yet, is feeling that the surgeons know best all the multiple factors. They know the disease processes, they know the natural history, they know the individual patient factors that might be other decision points, that might be geography and might relate to whether they're on multimodality treatment in terms of cancer patients. And so we have not created some peer review or processes. The anesthesiologist in charge does check with surgeons about their indications. But I think the surgeons have highly respected the intent. And because they've highly respected it, the institution has also highly respected surgeon autonomy in making the decisions on behalf of their patients.
Okay. So in getting into the main topic of our interview here, in New York, there's been an official ban on elective surgery from our Governor Cuomo, for the next 2 weeks. Is oncologic thoracic surgery truly elective?
Yeah, so I want to come at that from 2 points. So first is the point of 2 weeks. So the problem that we all have is that although it's easy to make proclamations about, in my healthcare systems, we said 4 weeks, Governor Cuomo says 2 weeks. I don't think any of us think that 2 weeks or 4 weeks, that this is going to be over and that somehow we're going to be back to taking care of patients normally. I really think from a pragmatic aspect, as cancer surgeons and cancer doctors, we're probably thinking more like 2 to 3, maybe even longer month time frame. And so I think that that has to be a factor in our decisions. And remind me the second part of your question, because you talked about 2 weeks from Governor Cuomo.
So just in broad-based terms, before we get into specific examples, is oncologic thoracic surgery elective?
Yeah, and there's now been several groups that have weighed in about cancer surgery. The American College of Surgeons um, uh, have some advice on their website. The Journal of the NCCN has just published something actually from our institution, from the Seattle Cancer Care Alliance, and essentially state that no, cancer surgery is not elective in general. I actually wrote our own kind of guidance for our practitioners here at the University of Washington, and it was that most cancer surgery has either medical and or psychological urgency and should proceed, at least in the way our current environment is in Seattle. But we also know that there are indolent, slow-growing cancers, obviously in thoracic, but in other areas as well, that I think we actually feel very comfortable can wait 2, 3, 4 months without impacting patients' outcome. Those are patients that I absolutely would be recommending that they defer surgery for now, and that we would revisit them when we get over the peak of this crisis.
So let's make this simple for our viewers and talk about some specific examples. 1 centimeter stage 1 adenocarcinoma, can it be postponed for 3 months?
Yeah, so I think the answer is yes, it can be. I'd say that's probably the one that sits on a gray zone. Yeah, that I actually had a discussion on a patient with a little bit larger tumor, but a shared decision-making discussion with a patient yesterday about the pros and cons of waiting, both in terms of their risk, because they have COPD, risk of getting infected with COVID-19, their increased risk of major complications or even mortality, as well as the risk of waiting. And so there are some decisions that are individualized, but I think a 1 centimeter solid stage 1A lung cancer is an example of a case that could be deferred reasonably for 2-3 months.
While we normally wouldn't do this, my institution is actually offering patients SBRT for these stage 1 lung cancers if the patient and the surgeon don't feel comfortable waiting. What are your thoughts?
Well, I guess I'll make a strong statement and then caveats. My strong statement would be SBRT is clearly inferior to surgery for stage 1 lung cancer. The radiation oncologists disagree with this, but when we look at our own surgical literature of the best patients that are medically similar, the survival of patients treated with surgery is twofold higher than that treated with SBRT. So in my own situation, I would recommend that those patients wait and have their surgery in 2 or 3 months. But the caveat is SBRT is a reasonable alternative to surgery. And if somebody is uncomfortable waiting or simply wants to choose an alternative therapy over surgery, then SBRT would be the next best choice.
Okay. Let's go into stage 2 disease. So say it's a 2-centimeter squamous and there's likely N1 disease on imaging. Most of these patients, we usually recommend going for upfront surgery and then adjuvant chemotherapy afterwards. Should this be a current exception to the ban on elective surgery, and should we be operating on these patients now?
Yeah, I'm going to give you two different directions you could go with those patients. So first, as I stated a little bit earlier, I wouldn't call cancer surgery elective surgery. Cancer
Right.
surgery is urgent surgery. And so it wouldn't be violating a ban. It would be moving ahead with appropriate indications for urgent surgery. And I would say that a patient with a more intermediate stage cancer, whether it's lung or esophagus or the other tumors that we deal with, chest wall tumors, and maybe certain mediastinal tumors might get into kind of diagnostic and staging aspects in a minute, that they should take priority unless one is getting to a highly resource limited environment. Now, you might be at that place in New York City at this point in time. We are not there yet in Seattle. And so if we still have hospital beds and we still have capability to use our ORs, I would still use it for those patients. The alternative is that those patients are going to be people that would get adjuvant therapy after surgery. And so a consideration would be to give them induction therapy that can delay the timing of surgery. So that's going to be very dependent also on the health system and the patient, and ought to be a multidisciplinary decision. Obviously, that patient may be a COPD patient who's now going to get systemic chemotherapy, is also going to be at a higher risk of poor outcomes if they do get infected. So there are trade-offs in those decisions that I think need to be made in a multidisciplinary way and in shared decision-making with the patient.
Yep. And I think a recurrent theme that keeps coming up in our conversation is multidisciplinary and shared decision-making. This is not a decision for one person to make.
That's right.
So for stage 3A patients, so say a patient who has obvious N2 disease on PET, these patients normally would get chemoradiation up front and then potentially surgery later. But we would be doing mediastinal staging, whether through an EBUS or a mediastinoscopy. Should we be performing EBUSs at this point and risk aerosolizing the virus in a patient who could be positive?
Yeah. So that brings up a point that relates to some discussions we've had here at the University of Washington in the past week, and we have just instituted a decision of doing preoperative testing for COVID-19 in all of our patients, including asymptomatic patients, because of the issue that you bring up of procedures like bronchoscopy and aerosolization and a higher risk to our medical personnel. That decision is not taken lightly, but is something we've just instituted. So I would say a patient like this, we would test and determine if they were COVID negative. If they were COVID negative, I would move ahead with kind of our standard plans for how we would stage and treat that patient. If they were COVID positive, I'd actually defer all management until they had gotten through the acute stage of their illness. And while bronchoscopy definitely has some increased risk, I think if we do the process of testing patients ahead of time, we probably normalize that risk. And we can also consider going old-fashioned and doing mediastinoscopy as a way of sampling lymph nodes. So my main point is I think I would not take shortcuts in staging patients that have apparent stage 3A disease so that we can still try to stratify them optimally. If we're resource constrained in the operating room, we might make decisions to treat somebody with definitive chemorads and not include surgery in a patient where our guidelines would say they could choose either algorithm. But I think so far we would still be treating those patients in a multidisciplinary fashion that would include surgery.
Great. This next case is actually a real case that was discussed on the robotic minimally invasive thoracic surgery community group, which is on Facebook. And someone had asked about a completely obstructing right upper lobe endobronchial carcinoid tumor and what the best options in our current era are. Should they perform a sleeve lobectomy now, knowing the risks and potential complications of the sleeve in light of our lack of resources? Continue to just observe the patient despite the symptomatic nature of the lesion and recurrent pneumonias, or debulk it endobronchially. But again, we run the risk of an aerosolizing procedure and utilizing resources. What do you think?
Yeah, that one is fairly straightforward from my point of view, because I would manage that in a certain way, even if we were not in a period of COVID-19 crisis. And that would be, I think it's far superior to endoscopically relieve obstruction in an obstructing carcinoid tumor prior to the plans for their definitive resection, meaning letting the distal airway clear, the post-obstructive pneumonitis clear. It also better demarcates the proximal and distal boundaries of the tumor. And so I'm an advocate of endobronchial initial management anyway. So I still would recommend that. And I would go back to my previous point about testing for COVID-19 prior to the endoscopy. But back to the point of indolent cancers, this is a tumor that once endoscopically palliated, I would defer their definitive surgery until we were at a different resource time and we could manage that patient in a more normal fashion with normal stresses on our hospital resources.
And for a typical carcinoid like this, it could be 6 months to a year before it really causes a problem again if debulked properly.
Yeah, I guess I'd hope it wouldn't be that long, but yes,
Right.
I think typical carcinoid,
Yeah.
if we palliate the obstructive component of it, could wait for a prolonged period of time before they'd really have a worse outcome from not having definitive surgery.
Great. So those were the specific examples I had prepared for you, Dr. Wood. Are there any other situations or examples that you've seen that you'd like to discuss with the viewers?
No, I think you've given some great individual examples that give people ideas of what to think about. I'll just make a couple of points that first, some of the guidance that we've provided, and there's documents that are coming out from the American College of Surgeons and from the Thoracic Outcomes Research Network. Some of that is to help our surgeons get their cases done if they're in a place where maybe prematurely administrators or anesthesiologists are limiting access to the OR and including cancer patients as elective patients. I'd say they are not elective patients. On the other hand, we also have to recognize that that many of our systems, mine included, are moving into a accelerating phase of increased resource limitation where we truly may only manage emergencies. So septic obstructed patients, esophageal perforation, and stenting for life-threatening complications, and not able to take care of our normal cancer patients. I think many of us will go through that phase, and you may be in that phase now in New York. So we have to recognize that as well. And lastly, I'll just say, all we can do is provide some guidance. This is not guidelines. There's not evidence basis behind this. We cannot point at a series of literature that gives a strong foundation for these decisions. I think we need to be flexible. I think we need to recognize unique local situations in our hospitals and with our patients, and be respectful of that, and try to make the best decisions we can for our individual patients, but also respecting the environment and the competition for resources and protection of our workforce that is necessary in this time of crisis relating to coronavirus.
I agree. Dr. Wood, thank you so much for your time. To all the healthcare workers on the front lines, thank you for what you're doing and stay safe.
Thank you, Dr. Mitzman.